one. Yes, sir, we can.
Dear doctor, it's my pleasure to invite Dr. K. Balaji from IAT International to present today's session on evolving strategy in advanced prostate cancer management. Doctor is having a rich experience in oncology, particularly in prostate cancer. Over to you, Dr. Balaji, sir.
Yeah, can you share the slides?
Okay, slides. 1 minute, sir. Please, 1 second, sir.
Sorry, just give me a moment.
Yes, sir. 1 minute.
Is my screen visible?
Sir, 1 minute, sir. From my side, the internet
Is my
is very...
screen visible? No,
1
it's
minute.
okay. I'm trying to open from my side. Is that
Not visible, sir.
Not visible,
not
sir.
visible?
Yes.
Is it visible?
Yes, sir. Now it's visible, sir. Yes, sir.
Yeah, okay.
It's fine, sir.
Yeah, good evening, one and all. Sorry for the delay and sorry for So today we will be like discussing about a very important like domain in the treatment of prostate cancer. Usually the prostate cancer treatment depends upon whether it is like metastatic, non-metastatic. If it is non-metastatic, it is mostly like loco-regional therapy combined with ADT and addition of like abiraterone. So that depends depending upon the NCCN risk classification from very low risk to very high risk. And another category non-metastatic will be like M0 CRPC. So coming on to the metastatic setting, it is broadly divided into two settings. That is metastatic hormone sensitive prostate cancer and another is like metastatic castration-resistant prostate cancer. So today we will be like mainly dealing with one of the four domain, that is like metastatic hormone-sensitive prostate cancer, where we stand and what is the standard of treatment. And with the end of the presentation, we will be able to make a decision if a patient comes to our OPD with the metastatic hormone-sensitive prostate cancer, how what all factor we should be considering in taking a treatment decision, and how to tailor the treatment for individual patients. So it is just a tip of the iceberg I will be discussing, because hormone sensitive prostate cancer itself will be like a very big domain to talk about. So this is the disclosure. And coming on to the standard of treatment, the standard of care for any metastatic hormone sensitive prostate cancer is the combination of ADT and one of the androgen receptor pathway inhibitor, irrespective of the timing of metastasis. That is like whether it is like low volume or high volume, metachronous or synchronous. So, irrespective of that, androgen receptor pathway inhibitor should be coupled with the ADT, and depending upon the risk, volume, and burden, and docetaxel may be included, and radiotherapy also will be decided upon the volume of the disease or the risk or the burden of the disease. And there is no role for intensification with docetaxel alone, as demonstrated by the phase 1 and RSM trial. So like definitely ADT and ARPI should be given to all the metastatic hormone sensitive prostate cancer. That is the baseline and baseline takeaway with the slide. And depending upon the risk and volume, whether docetaxel or radiotherapy can be added. So the two drug is standard when once you see a patient with metastatic hormone sensitive prostate cancer, that is ADT and ARPI. So coming on to that first, like only ADT was the standard of care in case of metastatic prostate cancer. So the first drug or the additional agent which came into play was the docetaxel. That is based upon the three landmark trial. That is the Charter trial, Stampede trial, and JTUG trial. So if you see all the study, the hazard ratio was like almost like 20 to 40%, and like the p-value was also significant for Chartered and Stampede, and it was not significant for GetUG, mostly because of the smaller sample size. But the Chartered and the Stampede included a very large sample size, and both had a different criteria to classify as low risk and high risk, high volume, not high risk, low volume and high volume disease. So coming on to the EAU guidelines, so if a patient comes with afferent metastatic prostate adenocarcinoma, so we have to continue the ADT, and we have to check for the adequate life expectancy. If it is not, then no afferent combination therapy. That is, if the life expectancy is less than 5 years or like very limited, then like no much role in like adding like intensification therapy or like doublet or triplet. So if there is an adequate life expectancy, then again the second thing which we will be considering is the volume of the disease, either low volume disease or the high volume disease. So the criteria for high volume disease, it should be more than or equal to 4 bone mets, including one or more outside the vertebral column or pelvis, or any of the visceral mets is present. So if the patient is having low volume disease, and both the EBRT and any of the ARPI should be added. And if it is suppose if the patient is like low volume, and even if the patient is very young and fit, then triplet also can be added. That is, apart from that of ADT and ARPI, if the patient is very young and fit, then even in low volume, there is no wrong in adding docetaxel to the treatment strategy. So if it is the patient is definitely high volume, we have to check for the fitness of the patient. If the patient is fit, then obviously triplet is the standard of care. We will be coming on to the evidence later. If the patient is not like eligible for a triplet therapy, then doublet with ADT and ARPI should be considered. So like both in the low volume and high volume, there is a role for triplet therapy. So that is the takeaway from this slide. So, initially we had discussed, we will be discussing about the evidence and why means because with the subsequent slide we will be like discussing the benefit of the triplet therapy or the doublet therapy, and like obviously who will be like high volume disease, like I said, who are like fit patient, and definitely all high volume should be afforded triplet therapy, and low volume disease obviously young fit patient who tend to have a like longer life expectancy. We try to achieve a better outcome with the first line of treatment, that is like to increase the OS and the PFS. So, which patient with metastatic hormone sensitive prostate cancer will benefit from addition of docetaxel? It's a systemic and meta-analysis of the individual participant from different randomized trial. So clearly, like addition of docetaxel to that of ADT favors the benefit, especially in the high volume synchronous, and then coming on to high volume metachronous, and then low volume synchronous, and then least will be benefited will be low volume metachronous. So this is also one of the category. So, which patient we cannot obviously avoid is like high volume with synchronous metastasis. Patient should be always afforded like ADT plus docetaxel. And like whom we can safely avoid like combination of ADT plus docetaxel will be like low volume and metachronous disease. So coming on to the next slide, so which patient with metastatic hormone sensitive prostate cancer benefit from docetaxel? So effect of docetaxel on. So all the stage irrespective of the term, stage, T stage. So both was benefited, but the benefit was seen more profound in like T4 stages. So you can clearly see the curve is like deviating from beginning itself. So the standard of care for metastatic hormone sensitive prostate cancer is ADT plus one of the ARPI, irrespective of timing of metastasis, risk volume. So that form the backbone of like treatment. Unlike with or without docetaxel, as we discussed in the previous slide, depending upon patient fitness and the volume of the disease and the synchronous versus metachronous presentation of the metastasis. And there is no role for like only ADT plus docetaxel as demonstrated in the piece 1 and Arasan side. So like without like ARPA, if we try to like intensify the ADT treatment alone only with docetaxel, there won't be much benefit. So always either triplet with docetaxel or doublet with ARPA. So that was the take home message from this slide. So coming on to the Arasan study, which was the only prospectively designed, because the peace trial was like initially the standard of care was different, and then they are updated depending upon the evidence and slowly added to the triplet regimen. So Arasans was the only prospectively designed trial to investigate the combination of like docetaxel plus ADT plus darolutamide, that is ARPI. So it is a global randomized double-blind placebo-controlled phase 3 trial. So it was a well-randomized trial. And coming on to the inclusion criteria, so patient with metastatic hormone sensitive prostate cancer and good performance, preserved performance status, and candidate for ADT and docetaxel, that is the fitness for both. And stratification was made depending upon the extent of the disease. So M1A stand for non-regional lymph node, M1B for bone only mets, and M1C extra skeletal mets with or without the bone mets. So they also stratified based upon the alkaline phosphatase level within normal limit or the upper limit of normal. So the randomization was 1:1, and the standard arm the comparator arm was like placebo plus ADT plus docetaxel versus the investigation arm was docetaxel plus darolutamide plus ADT. So the darolutamide dose was 600 mg BD, that is twice it is given. So the endpoint was like primary was obviously the overall survival. So that is the standard if you take any of the trial. So secondary endpoint was like castration resistant duration and pain progression, symptomatic skeletal mets, mainly a patient related progression free survival if you are taking, or worsening of symptom related to skeletal event was the secondary endpoint. The final analysis was conducted after 533 days, and secondary efficacy endpoint were tested hierarchically. So the first cycle of docetaxel was administered within 6 weeks after the start of the study, drug at the discretion of the investigator. So coming on to the second trial, which we'll be discussing is the Peace-1 trial. So it was not prospectively designed that triplet arm was the investigator arm, because it was like conducted over a period. Initially, like almost 40% of the patient does not have the triplet arm, and slowly only the patient started receiving the docetaxel. So coming on to the inclusion criteria, it include de novo metastatic disease, and then disease extent definition was high versus low volume was used. Performance status also like same to that of Arasan, that is well fit patient, and less than 3 months of ADT prior to randomization, and no prior cytotoxic chemotherapy or biological therapy should be taken during the previous previous this one. So stratification was based upon the performance status, metastatic site, that is lymph node versus bone versus visceral, and type of castration, that is orchidectomy versus medical castration. Another will be whether docetaxel was given or not, because initially they didn't have the docetaxel arm in the initial period of the trial. So the standard of care was either ADT or ADT plus docetaxel. That's what I said. Almost 40% of the patient didn't receive docetaxel because the trial was initiated before. So after the docetaxel become like care, they added the docetaxel. Only 60% of the total population received the docetaxel. So it is like it is like two. It included several arms. So arm A is standard of care. Arm C is like standard of care plus radiotherapy. Arm B is like standard of care plus abiraterone. Arm D is like standard of care plus abiraterone plus prednisolone. So again, if you see, the primary endpoint was overall survival and radiological progression-free survival. Secondary will be like almost similar, like castration-free survival or progression-free or like quality of life, and skeletal events, everything was taken. So Peace-1 is an open label study with 2x2 factorial design that was only conducted in the European. So Peace-1 was amended to the following care. So from 2013 to 15, only ADT was the standard of care. When 2015 to 17, when like docetaxel of the meta-analysis of the Chartered and the Stampede and the Getty UG came, so docetaxel was permitted. And then from 2017 to 2018, docetaxel mandatory as a part of like standard of care. So after the meta-analysis from 2017, all patients were mandated in the standard of care arm to have the docetaxel. In 2015 to 17, it was like on flow of the evidence. So if physician prefers, then docetaxel was permitted as part of standard of care. So in Arasan, all the 1,306 patients enrolled received. So that is the difference. So in Peace-1 trial, only 61% of patients received the triplet regimen. But in Arasan's, all the patients like enrolled in the standard of care received docetaxel versus like a doublet versus triplet. So that is very important when we are analyzing the outcome of the study. So again, that is the reinforcement of the previous talk. That is the 100% of the patient receive ADT plus docetaxel. But in this Peace-1, like only 61% of the patient receive ADT plus docetaxel. So coming on to the outcome, that is a survival. So you can see clearly that there is a separation of curve will be at the beginning of the treatment itself. That around like 6 months, you can see 6 to 9 months that curve started to differ. And if you take almost at 4 years, the survival rate was 63% compared with 50%, which is very much important, because patient tend to have like longer survival, especially in like cancer like a prostate, breast. So where we tends to increase the progression-free survival and the overall survival also. So even this 13% difference will be translated into much better outcome in the clinical scenario. So coming on to the Peace trial, even though the difference was there was a separation of the curve, but it was not till during the later time. That is after the 2 years only, you can see the curve started to separate. So coming on to the So patient in the darolutamide arm stayed on the treatment 2 years longer than the patient in the placebo arm and had a similar discontinuation rate due to the adverse event. So when we compare the tolerability and the quality of life and the side effect profile, darolutamide is like well tolerated and the side effect will be much less as compared to that of abiraterone. And the discontinuation rate also is very less. So darolutamide also didn't affect the outcome of administration of chemotherapy. That all the full cycle of 6 cycle of docetaxel could be administered with darolutamide compared to that of placebo. So it was like comparable. So mainly attributed to the tolerability of darolutamide. If the darolutamide had like much of a side effect, then the patient would not in the intensification, that is the triplet arm. Obviously when we compare with doublet versus the triplet, obviously when we add another drug to improve the outcome, obviously we expect the toxicity profile also to improve. But that is a good thing about the darolutamide. When patient in the darolutamide arm does not need any like compromise in the administration of the docetaxel, so that is the thing which has translated into early separation of curve and like better clinical outcome also. So all these things matters when as a clinician we try to treat a patient. When patient is happy with the side effect profile, obviously they tend to adhere to more protocol per protocol, and the outcome also will be better. So in that aspect, like darolutamide is a well tolerated drug. So this is the comparison of grade of like toxicity. If you see all the grade 1, grade 2, grade 3, grade 4, grade 5 adverse event were almost matched between the two arms. So in piece 1, if you see the grade 3 more than or equal to adverse event were comparatively little higher in the triplet regimen compared to that of doublet regimen, and mainly hypertension and hepatotoxicity were little higher in that of triplet regimen. And in Arasan trial, we can see like the level of grade of toxicity, grade 1, grade 2, grade. But in this, the level and the grade of toxicity was not reported separately. So in Arasens, like already we discussed, the toxicity was like almost comparable between the two arms. Only the rash and hypertension were slightly higher in the darolutamide arm compared to the placebo arm, which is like easily manageable in the clinical scenario. So the standard of care for any metastatic hormone sensitive prostate cancer is ADT and one of the ARPA, like we already seen. So irrespective of the timing of the metastasis. So depending upon the risk, volume and burden, whether docetaxel or radiotherapy needed to be administered or not, we have to take a call. And there is no role for intensification with docetaxel alone. That is like only giving ADT and docetaxel without ARPA is not of much benefit, as already demonstrated in the piece 1, because triplet is always far having a better outcome compared to that of doublet. That is like ADT plus docetaxel. So always the take home is that when the patient is like a fit, high volume, synchronous metastasis, always consider triplet regimen over the doublet regimen. And the doublet, if we cannot administer the triplet because of like performance or other issues, always give ADT plus ARPA rather than docetaxel. That is the thing. So this is the advanced prostate cancer concern guidelines. 2024 panelists voted their opinion regarding the management. In patient with high burden metastatic hormone sensitive prostate cancer that are chemotherapy fit, do you recommend the triplet therapy ADT plus docetaxel plus ARPA? So almost 54% voted for like combination therapy, and but only in selected. So like almost if you take 94% opted in favor of triplet regimen. The selected patient they tend to mention is like that already discussed, like synchronous metastatic disease and the fit patient. So almost 94% of patient, yes, if the panelist voted, yes, if the patient is like metachronous, high volume and fit, obviously we prefer triplet regimen. That is the combination of ADT plus ARPA plus docetaxel. So that is the main take home lesson from this slide. So in patient with low burden metastatic hormone sensitive prostate cancer that are chemotherapy fit, do you recommend triplet therapy, ADT plus docetaxel? So synchronous disease, obviously, if you say like yes, in majority of the patient was less, but like no, but selected patients that what synchronous low volume and fit. Obviously, 47% of the panelists voted for that, and almost like remaining voted for no. So there is no harm even in low burden metastatic hormone sensitive patient. If you think like patient is fit, then we can obviously no harm in giving like docetaxel also to the tough doublet arm. And if asynchronous, obviously it is better to avoid the triplet regimen. Only doublet can be considered. So that is the take home from the slide. So safety consideration. So what to consider with the triplet? So when we are giving triplet, what are the concern we have to infusional treatment, chemotherapy toxicity, and administration time? So all these things play a role because like patient has to be monitored during chemotherapy and patient to come and as a daycare like how to get admitted and then have an infusional treatment and the side effect and monitoring associated. All these things will be a tedious process, especially when we are opting for the triplet therapy. But doublet therapy, like mainly what are the problem because we need to like because all the cardiac and the other edema related for problem will be volume overload problem will be seen with the ARPA. So the pill burden and the adherence and everything will be like is an important aspect when we are like giving an oral ARPI. So the two studies, that is the PEACE-1 and ARASEN, demonstrated that the ADT plus docetaxel is not enough, and that addition of ARPI improves survival. And additional intensification of triplet combination treatment approach, that is with the APRI, ARPI plus the ADT plus docetaxel, should be considered a new standard of care approach in the patient with metastatic. So, if like a triplet and a fit patient and synchronous metastasis, triplet should be considered. And to proactively manage adverse event of new treatment option, optimize treatment outcome. So always like we should ensure that the patient quality of life is not compromised. So when we are comparing between the side effect profile between the PEACE and the Arasens, so the Arasens has a better tolerability. That is, the darolutamide has a better tolerability and doesn't impair the administration of the docetaxel. So these two things are very important as a clinician when to come to convince the patient to take the triplet therapy, because like these are the main concern patient will be like whether the patient is able to tolerate, whether what is the side effect, and will it impair the day-to-day activity, or like whether they can go back to work if they are working. So all these things play an important role when we are like taking the decision regarding like selecting a treatment option in the triplet regimen. So obviously the side effect profile in Arasens is very favoring, and darolutamide is like well tolerated drug. So obviously the multidisciplinary care is the key to success, and all eligible patients should be offered the benefit of all the proven and effective treatment to enable living with preserved, improved quality of life. So that's the thing. So obviously with PEACE-1 and Arasen, we know that the overall survival is improved. So whenever like in oncology, like especially in the metastatic setting, we usually take two things. One is the first is the survival outcome and the progression-free survival. If these two things are achieved between the two drugs, then the decision regarding which drug to pick up comes by the side effect profile and the quality of life. Obviously, the drug with low side effect profile and better quality of life will be like preferred drug over the another drug, even though the survival outcome and the progression-free survival are similar. So that is with that, I conclude my presentation.
Thank you, Dr. Balaji, sir, for that insightful and thought-provoking presentation. The practical perspectives on managing the transition from MHSPC to MCRPC, along with the importance of timely treatment and intensification. Sir, shall we wait for some time if any questions are arising?
Yeah, sure.
Sir, before that, with your permission, I would like to ask, sir. Sir, you are recently used one patient for darolutamide. So kindly, if you can please share your experience.
So this is a 65-year gentleman. Like a patient was having like initially came to our hospital for the management of like aortic aneurysm, arch of aortic aneurysm. So during the workup for the arch of aortic aneurysm, like CT scan revealed multiple like vertebral mets. So in view of his age, 65, so we tried to do like a whole body PET-CT, so which suggests you of like prostate lesion with multiple axial and extraaxial metastasis. And the PSA was 100, and so like we did the PSMA scan also, which was showing like uptake. And when we did the biopsy, so it was turned out to be like prostatic adenocarcinoma, acinar adenocarcinoma, and the Gleason score of like 4+5, that is 9, and grade grouping of like almost 5. So he was like afferent metastatic hormone sensitive prostate cancer, but patient was having extensive skeletal mets, that pelvic pain and the vertebral pain and the femur and the tibia was fully studded with mets, that he cannot like able to move his leg, mainly because of pain. There was no neurological deficit, so patient was literally bed bound. So in our tumor board, there was like a debate whether to proceed with the fixation of aortic aneurysm, or like whether to proceed with the treatment of like metastatic hormone sensitive prostate cancer. The funny part, when we sit as a multidisciplinary team, when non-oncologists also with us, it is not too common, but usually when they say it is like metastatic, they say like a patient is anyhow gonna die, why we have to intervene. So like we actually like able to quote this one of the Arasan trial that we actually quoted in our MDT, stating that the 4-year OS is almost 63. They couldn't believe their own eyes, stating that how it is possible in a metastatic setting. That what we said, that the oncological treatment and the outcome has pretty evolved over the past 2 to 3 decades, that even the metastatic patient tend to live. So the final decision was to start the treatment for prostate cancer, because there is no emergency indication to intervene for the aortic arch aneurysm. So finally, it was to start the treatment for that metastatic hormone sensitive prostate cancer, to re-evaluate the patient once the disease is controlled after 3 to 6 months. So initially, I started the patient with degarelix, that is antagonist, and then like slowly I started adding the patient with darolutamide 300 mg. So like within 3 4 days, patient started to develop like raising in urea, creatine, and uric acid, and the patient started to have sustained hyperkalemia also. Like initially, we were thinking like patient was dehydrated because of the summer and the thing, but because we never seen like especially tumor lysis in the solid setting. So slowly the uric acid started to pump towards like 12 13, and the potassium also started to rise till 6.8. Then we started the anti-tumor lysis management, and with hydration everything, it is settled. So just after 2 weeks, when we repeated once the tumor lysis settled, just to reconfirm whether because of tumor response, the PSA from 100 just dropped to like 17, just with 300 mg dose of twice a day. And when we did like a PSMA scan, because the patient was also simultaneously planned for PSMA therapy, because there is a recent evidence from the European Society of Urological Oncology that adding like a PSMA therapy upfront also increases the progression free. So as a part of that, when we did the workup, the nuclear medicine consultant were pretty like surprised. All the vertebral mets and the bone mets has gone. Only there is small lesions of island of lesion only in the pelvic bone. And then when patient took the PSMA therapy also, again patient went into tumor lysis. So twice he went into tumor lysis. Anyhow, we managed, and now patient is fully able to walk. Patient was bedridden when he came, even with loss of like bladder control. Now patient is avoiding able to walk, and now doing well. And recent PSA level was 2. It was normalized. And anyhow, we are planning to initiate docetaxel also next week. So patient is happy, and now we escalated the dose of darolutamide for past 1 week to 600 mg. So clinically, he is very happy, and like PSMA scan also like showing no disease. So that is the beauty of like current therapy, that the patient is well tolerated without much side effect, and patient never even complained any problem with the that is with the adherence of the drug during the treatment. No side effect I could appreciate during my therapy. So it's a wonderful drug. Only
Thank
the
you, sir.
cost is a problem. So that's the thing.
Thank you, sir. Thank you. Thank you very much
Okay.
for giving such a great remarks on darolutamide. I hope
Yeah.
there is no question in the group, sir. Once again, sir, I
Okay.
thank you very much for the excellent presentation and sharing your clinical practice also simultaneously. Once again, sir, we are planning such an event simultaneously in the coming months. Once again, thank you, sir. Thank you very much for joining the meeting. Thank you, sir.
Yeah, yeah, sure, sure. Thank you. Thank you. Thank you.
Thank you.
So any issues?